Good evening, everyone. Welcome to this PhysiQuip webinar. My name is Jamie. I'm the product manager for the Alpinion range of ultrasound systems at PhysiQuip. We're delighted to be joined by Dr. Qasim Akram this evening, who will be presenting on POCUS within rheumatology. So Qasim is a EULAR ultrasound instructor and is regularly invited to speak at local, regional and national level conferences. He's a founder and director of the Rheumatology ultrasound course in Manchester. The format of tonight will be a short presentation from Qasim, followed by Q&A. So for those of you that have joined the session live, if you have any questions, please submit these within the Q&A tab. And I'll now hand over to Dr. Akram for an introduction and then on to the presentation. Thank you.
Thank you very much, Jamie. So my name is Dr. Qasim Akram. I'm a consultant rheumatologist based at Stepping Hill Hospital. My specialist interests are really ultrasound and how it kind of integrates with rheumatology. Within that, I look after lots of patients with early inflammatory arthritis and also giant cell arthritis, where we have most of the applications of ultrasound. So, I mean, today's talk is really to give you an introduction of the sort of cases that we see and also how we use ultrasound within our day-to-day practice. So I'll give a brief overview of some of the commonest inflammatory arthritis conditions and also the typical ultrasound appearances as well and how it can help us diagnose these conditions and then make a treatment plan. So what we know about POCUS in rheumatology is that usually it's useful as an assessment of disease presence as well as disease activity. So a lot of inflammatory rheumatic conditions tend to be active or inactive, and it's really, really helpful with that. What we do also stress is that it's used as an extension of clinical examination. We don't say that, just because you can do ultrasound, that's it. You don't need to rely on anything else. In fact, the majority of the time, I rely on my clinical history taking examination, and this really complements what I'm trying to look at. One of the main benefits of ultrasound is that it can detect very, very early signs of inflammatory disease, and that's one of the main reasons why rheumatologists have started to learn to use this, because before we used to send these patients to radiologists, which we still do, but it can take some time for the scan to happen, then the report to come back, etc., etc. So it just makes sense that we can actually see these patients and then scan there and then, and that's how we tend to use ultrasound. And I think that's probably one of the main benefits. We can also detect any responses to treatments. We have lots of very clever and fancy medications now that treat rheumatic conditions. Previously, rheumatic conditions would cause a lot of immobility, lots of disability, lots of long-term changes, but we don't really see that anymore. And in fact, we've probably put orthopedic surgeons out of business through that. And finally, I also use it to guide joint interventions as well, which I think most of you that do ultrasound would do as well. So what are the advantages and disadvantages of ultrasound? Well, it's pretty much the same as any other modality or any other condition that we use ultrasound in. We know it's safe, we know it's reliable, we know it's well tolerated, and it's very, very cheap. It's also dynamic and can be performed at the bedside, and it allows a multiplanar assessment. What I find in rheumatology is that it actually helps patients really understand their disease. It really helps them understand what's actually happening at this present moment in time. Sometimes patients will say, oh, I've got pain and stiffness. And then if you can show them on the scan, look, this is what's going on, this is what we're going to do, it really kind of helps them feel a bit more empowered. At the same time, it's actually quite good for lots of non-organic conditions as well. We see lots of non-inflammatory musculoskeletal conditions where people will have lots of issues with their joints, lots of pain, etc. But if we can actually show them that there's nothing wrong with their joints, that can again give them lots of reassurance, and then they can focus on what they need to do, whether that's pain management, physiotherapy, and things like that. The main disadvantages, and this is what I really stress, is that it is operator dependent, requires lots and lots of expertise. I have trainees with me who spend a year learning ultrasound, and even then, I mean, they need a lot more time to develop competencies. So my recommendation always is that, you know, if you are learning ultrasound, learn from the right people, and just make sure you go for some sort of accreditation, and especially with a niche specialty like rheumatology. So moving on to our cases. So what I'm going to do is run through a couple of case examples and just show some ultrasound images as well. So the first case is a 34-year-old lady. She has a 6 weeks history of pain and stiffness of the small joints of her hands, wrists, and ankles. Her blood tests show that she has a slightly elevated CRP. Her rheumatoid factor, which is a test that we do for rheumatoid arthritis, is slightly raised, but her anti-CCP, which is another test that we do, which is a bit more specific, is normal. She goes on to have x-rays of her hands and her feet, and they're all okay, actually. There's nothing there that we can identify. She also has a clinical examination which doesn't really detect any synovitis, but at the same time, when you are feeling and examining her joints, she's very, very tender, especially across the wrists, especially across her knuckles, and also the PIPJs and the ankle joints. So this is her ultrasound scan. I've put in 3 images here. So if we focus on the image on the left-hand side, which is labeled as number 1, this is an ultrasound image of a radiocarpal joint. And what you can actually see if you look at the 4 green arrows is that there is some synovial hypertrophy. So that's not normal. It's normal to probably have a little bit of synovial hypertrophy, but this is quite significant. So that would indicate to me that, you know, there is something going on. I've not included any power Doppler there, but usually you should really look for any power Doppler activity to see if there is any active inflammation or not. So if we go on to look at example number 2, we can see that there is some swelling over the MCP joint here, which you can see that's labeled. And what you can actually see is that there is some synovial hypertrophy with extension beyond the actual joint line. Looking at number 3, this is an ultrasound image of the tibio-talar joint. And what you can actually see here is the 4 arrows, the 4 stars, I beg your pardon, which indicate that there is an effusion here. So indicating that there is some sort of inflammatory activity going on here. So if I put her clinical examination, her laboratory abnormalities, I will diagnose this lady as a rheumatoid arthritis. So we gave her some steroids, and then we made a plan to treat her with methotrexate. So cases like this are very, very common with rheumatoid arthritis. And what we can do is that if we can treat these patients early, we can really improve their long-term disease outcomes. So in terms of rheumatoid arthritis, what sort of features do we look for? Well, you know, we've seen synovitis, which I've showed you, a synovial hypertrophy. But here on the image on the left-hand side, number 1, you can actually see that there is quite a lot of synovitis within this joint, and you've got lots of power Doppler activity. So you know, this is one of the commonest features that we tend to see. We also tend to see some flexor tendon inflammation as well. So here you've got some flexor tenos synovitis on the on image number 2. And if we look at image number 3, you've got some extensor tendon inflammation as well. Again, another common feature of this condition. And then if we look at number 4, this is an erosion. So an erosion is usually kind of a break in the bony cortex of the bone. There's usually some discontinuity, and usually it indicates some form of aggressive disease. Normally, we don't really want to see cases of 4 because that tells us that this person's got quite aggressive disease and quite late disease as well. If they've got inflammation, that's something that we can sort out. So when we are examining these patients, we do obviously need to really focus on their joints, and we carry out quite an extensive examination looking at their wrists, the MCP joints, the PIP joints as well, and the flexor tendons and the carpal tunnel regions, and then move on to the feet. So we'll move on to case number 2. This is a 28-year-old solicitor who has a family history of psoriasis. She has a 4-week history of painful joints in her hands, her lateral elbow, and also around the back of her ankle. So a fairly short history, but fairly distinct and complaining of specific symptoms. She's also had some back pain for the last couple of years, never really investigated it. It's always sort of resolved with a bit of briefing. She's also had an episode of a red eye as well, which again resolved by itself. So her blood tests are normal. Her rheumatoid factor and anti-CCP is also normal. When you actually look at her, she doesn't have any signs of any psoriasis, but she's got what we call nail pitting, which can be a sign of psoriasis affecting the nails. She also has some tenderness over her DIPJs, as well as lateral epicondyle and some swelling around the Achilles tendons. So if we look at this lady's ultrasound, so after the examination, she goes on to have an ultrasound scan. Here you've got example number 1, where you've got some, this is an MCPJ. And if you actually look at the actual joint, that doesn't look so bad. But you've got lots of change and lots of swelling, more localized to where the extensor tendon is, and you've got lots of inflammation there as well. So this indicates that this is some extensor tendon peritendinitis. If we look at example number 2, this is an ultrasound of a lateral elbow, which indicates some Doppler activity at the lateral epicondyle, indicating that this lady has what we call enthesitis. So enthesitis is usually inflammation at the site of insertion, normally when the tendon inserts onto the bone, which is quite a classic feature of psoriatic arthritis and ankylosing spondylitis. She also has an ultrasound scan of her ankles, and what you here can see is lots of intense power Doppler activity localized within the actual Achilles tendon, both on long axis view but also on short axis view as well, which again indicates that there's lots of neovascularity within the Achilles tendon, indicating that there's some sort of inflammatory process going on. There's actually quite a lot of stuff going on within this Achilles tendon on ultrasound. She's got some enthesophytes. There's also a slight bit of effusion and some calcification as well. So following all these ultrasounds and the clinical history and examination, we diagnosed this lady as having a form of psoriatic arthritis. She was given some steroids, and again, DMARDs were started as well. So again, it indicates to you that these patients are young patients. We can treat them early, we can get them back to work, etc., etc. If we can really improve their diagnosis and early treatment. So Focusing a little bit about ultrasound in PSA is very similar to rheumatoid arthritis. We tend to see synovitis, which is inflammation around the joints. We see tenosynovitis. We can see erosions, but less common. But one of the commonest things about psoriatic arthritis is that it affects the extensor tendons a lot more, or the tendons in general. So we tend to have more of an intense Doppler activity around the tendons, but also we tend to get involvement of the enthesis, and this is usually where the tendon inserts onto the bone, and you can see that in lots of different places. Quite commonly, you can see this at the nails, the nail bed, at the around the DIPJs, but also you can see it around the flexor tendons as well. But also you can actually look at the collateral ligaments around the small joints as well, and that can also show inflammation as well. So it's really important that if you have someone with psoriatic arthritis, that you are looking at all these different places as well, because if you don't, you could miss some inflammation there. So moving on to our next case, this is a 62-year-old man. He has some stiffness of his shoulders and his hips with some pain in his MCPJs. He's unable to lift his arms above his shoulders and head, and his mobility significantly reduced. Now, just to put into context, this is a very, very fit and well 62-year-old man without any medical problems, very active, walking, going to the gym, riding his bike, etc., etc. So this is quite a big. This has had a significant detrimental effect on his sort of day-to-day living. When you examine him, he's got real restriction of movements throughout, really, very much like a frozen shoulder. He can't really move his shoulders, but he's also has the same with his hips as well. When you look at his hands, he's got puffiness around his knuckles, and his inflammatory markers are very, very high. So his ultrasound scan shows that he has some inflammation around the biceps tendon. So if we look at the first image at the top, this is an ultrasound image of the biceps tendon, and you can actually see that there is some tenosynovitis around this, which is quite classic for this condition. Then I've also looked at his hip joint, which is what we see on number 2. And here you can see that he's got an effusion and some synovitis here. So given the clinical history, given his clinical examination findings, and also the ultrasound findings, I've diagnosed this gentleman with a condition called polymyalgia rheumatica, and I've put him on a course of steroids as well. Now, polymyalgia is a very, very steroid responsive illness, which usually improves after around 12 to 15 months, but patients do need to have steroids for that long period. But what they will tell you is that as soon as they start steroids, within a few days or so, their symptoms do significantly improve. So our last case is a 48-year-old solicitor. He's been having some intermittent joint pain for several years, really, affecting his feet, especially the great toes. He recently was abroad and he had an acute flare-up of this. He had involvement of his knees, ankles, and feet, and it wasn't really responding to any inflammatories. He stressed to me that he doesn't drink any alcohol, but he was consuming quite a lot of seafood. When I've examined him, there's no evidence of any gouty tophi or any other obvious evidence of any gout, but he does have some tenderness across his MTPJs and swelling over the knees. Now, with a case like this, what you want to do is rule out rheumatoid arthritis, psoriatic arthritis. So reassuringly, his blood tests do show a normal rheumatoid factor and anti-CCP, but his uric acid level is quite high, indicating that he may have gout where the uric acid level is elevated. So he goes on to have an ultrasound scan to try and sort of differentiate things. And what the first thing that you probably know on ultrasound is that he doesn't have any of the classic features of rheumatoid arthritis, psoriatic arthritis. However, what he does have are features of gout. So if we look at the image on the left-hand side, image number one, he's got some, if you look at the black arrows, they indicate this kind of calcification around the hyaline cartilage. And this is quite classic of gout, and this is what we call the double contour sign. And if you look at the other arrow, which is a green arrow, I think, which does indicate that there's a little bit of calcification there, which could represent what we call a gouty tophi. So when you get gout, you get lots of clumps of uric acid, which kind of forms into this like sugar lump type appearance, which you can see on ultrasound. Sometimes it's not visible to the naked eye. When you're examining, you can't detect it either, but ultrasound really helps with that. If we have a look at number two, you can actually see that this is a femoral cartilage. Sorry, just go back. The femoral cartilage, and the black arrows indicate that this calcification here, which you shouldn't really see, and that's uric acid crystals which have deposited, creating this tram-line appearance. So quite confidently, I was able to diagnose this gentleman as having gout. And then we started him on some urate lowering treatment as well. And he's doing well. So I've told you about ultrasound and how it can be useful in gout. Here we can actually see some images to show this, to elaborate on this further. If we look at the image on the left-hand side, this is image number one. This shows the first MTPJ, which does show evidence of a gouty tophi like I described. And you've actually got some power Doppler activity around this gouty tophi, and you can actually just see that around there. And that is clumps of uric acid. On number two, this is an ultrasound image of the extensor tendon, the tibialis anterior tendon, which actually does show evidence of extensor tendon tophi as well. So when you do get gout, it can deposit in lots of different places as well. So you can get it mainly in the joints, but you can actually get it in the tendons as well. So it's important when you're examining, you're looking at the joints, but you're also looking at the tendons as well to see if there's any sort of deposits. Now, some of you may have also heard of a different type of gout called pseudo gout. And that is usually due to calcium pyrophosphate deposition. And again, that can be seen on ultrasound as well. It doesn't have the typical appearances of uric acid gout, and it can cause calcification in tendons. Typically, you can see it in the knee menisci. You can also see it at the lateral wrist at the triangular fibrocartilage as well. So here you've got a slide which actually shows a direct comparison between pseudo gout and gout. If we look at image number one, this is an elbow joint. This is a healthy elbow joint. Here you can see a nice smooth cartilage which looks quite dark. There isn't any calcification or anything like that. But if you actually look at image number two, now you've got this white kind of appearance, this hyperechoic appearance within the actual cartilage, and that indicates that there is some form of crystal within there. And typically pseudo gout doesn't deposit on the surface, it deposits within the actual cartilage. So again, that's quite pathognomonic of this condition. And then finally, if we look at number three, you've got this double contour sign, which again is typical of gout. So the difference between uric acid gout is that it deposits on the surface of the hyaline cartilage, whereas pseudo gout is usually within the actual cartilage. So that is a quick tour really of some of the commonest conditions that we see in our clinics and some of the ultrasound appearances there. And this is really to give you a bit of an introduction into rheumatology, and these are things that you may have seen already. So what we know is that it's helpful in a range of inflammatory conditions. Early diagnosis is crucial, and that's why we want to use it. That's why I've learned how to use ultrasound, because I've been able to go and set up one-stop shop clinics where we pick up people that have a very early diagnosis of inflammatory arthritis, and we see them within within a few weeks. Even within the current constraints of the NHS, we're still prioritizing these patients because these are national recommendations where patients like this should be seen earlier, and disease modifying treatment or even advanced biologic treatment should be started. Ultrasound also provides a really accurate assessment there and then on the day, and I think it's really good. Patients really benefit from this. I think it empowers them with their disease. But I think the final point really is that rheumatology in itself is quite a niche specialty, and I think you have to be very careful how you use it. You need lots and lots of training, lots of expertise. I know there's lots of people that do it in the community, but they may not have access to rheumatology. And I do stress trying to build up some relationships with your local rheumatologist as well. So if you are scanning, you've got somewhere to refer these patients and things like that. All right, I'll hand over to you, Jamie.
Okay, thanks, Qasim. That was really insightful, really interesting to learn a little bit more about how you're using ultrasound within your practice. So what we'll do now, we'll start by answering some of the pre-submitted questions. And if you haven't already done so and you do have a question, feel free to use the Q&A tab within the bottom of the screen to submit a question. So the first one, how easy is it to access the one-stop clinic that you've got at Stepping Hill? So I imagine that question relates to sort of how long can a patient expect to be seen at the clinic, after referral?
Yeah, so that's a good question, actually. So normally, what we tend to do is we've actually got a pro forma that GPs can actually fill out, or first contact physiotherapists even. And what we tend to do is, on this form, we've got lots of different criteria. And if they meet the criteria, we would try to see these patients. Usually, the recommendations are that we should see these patients within 3 to 4 weeks. And I think, given the current issues around the NHS waiting list, I must say that has gone back a little bit. But even then, we are seeing these patients within, less than 6 weeks or so. If it's going to take a bit longer than that, we tend to give, a plan, because the important thing here is that, we want to see these patients, we want to see what's happening with their disease before any treatment has been initiated. Because one of the other things about ultrasound is that if someone goes on to treatment in the community with steroids, etc., it can alter what we're seeing on ultrasound, and it doesn't give us an accurate picture as well. So normally, we still manage to see these patients within a few weeks.
Okay, yeah, that's interesting to hear. And that's pretty good in the current climate, as you touched on, I think. The next question, what do you believe is the best way to become appropriately qualified for POCUS? I mean, I guess that's maybe quite a broad question. It depends on your speciality and what conditions you're seeing, whether you're rheumatology or if you're an extended scope physio, looking at all MSK conditions.
Yeah, I mean, it is a broad question, but I think the general principles are, I mean, when I was learning, I remember I started learning around 10 years ago, and maybe even longer. And I remember just bugging the radiologist and just saying, look, can I come? And I remember he never used to let me scan, but you just used to watch it.
Yeah.
And through that persistence, he used to sometimes say, okay, fine, I've got to do this. Why don't you just scan here? Do this, do that. And it kind of gave me a bit of an introduction. So I think wherever you're working, I think you should have good links with radiologists or anyone that's scanning, like a rheumatologist or anyone that's scanning. You should try and sort of build links with them. And I think there's no substitute for, kind of lots and lots of practice. I definitely recommend some formal accreditation, actually, because ultimately, once you go out, and start practicing independently, if something goes wrong, you need to show, you've got some evidence really that, that you have had some sort of formal recognition of this. So I
Yeah.
think, there's quite a lot of different courses out there. I think, there's PG certs. that's probably what I would recommend, really. But I know that within the PG certs, you need to have some sort of mentor, um, where you're able to do at least 300 to 400 scans, seeing a wide variety of things. And also, if you have a specific interest in, say, rheumatology, I think it's not unreasonable to kind of contact your local rheumatologist and say, look, if they are scanning, or wherever, someone may be scanning, say, look, would you mind if I pop into a few clinics and, maybe shadow them for a period of time as well. So I think it's difficult because there isn't, a formalized structure. And I think, people are learning by themselves. But I think, the best way to kind of be very competent is to kind of, do some formal accreditation and practice lots and lots of scanning.
Yep, yep, that's really interesting. Also, can you share or discuss the current research to support the case for POCUS within an MSK primary care setting? So I guess this isn't exactly relatable to rheumatology, but I'm not sure if you have any colleagues, perhaps, Qasim, or if you
Really.
hear on the grapevine about how effective this is within
No,
primary care.
yeah, it's difficult. I mean, I think I can see the benefits of it, absolutely. But I think, again, I would stress that, people are trained properly. I think, one of the things is that, it's the unknown, really. Sometimes if someone's scanning, in primary care, we may not know who that person is. We don't know what experience they've had. Whereas if someone is scanning in my hospital at Stepping Hill, if it's a sonographer, I can just contact them or I can speak to the radiologist.
Yeah.
So so I don't see there being a problem with it as long as you're properly accredited, you're properly qualified, but also I would kind of make yourself aware to, the radiologists or orthopedics or rheumatology, wherever you're sending these patients in, just to say, look, this is what I'm doing, blah, 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 et cetera, et cetera. So I think that can, that can help you.
Yeah, just to build those links up and that
Yeah.
communication lines. Yeah. Next question. How early can we pick up ultrasound changes in rheumatoid arthritis?
Most cases of rheumatoid arthritis, you can pick it up really quickly, very early. I mean, it's difficult to give an exact kind of, time frame, but normally within sort of onset of symptoms, within, as soon as someone's got symptom, you'll be able to see it. So I think recently I had one of the orthopedic surgeons referred to me, someone had just randomly out of the blue, she just had a swollen joint, and she just contacted him as a private patient. She had previously seen him for something else, and I happened to be in clinic at the same time. He said, "Look, come have a look at this." And it was literally after a couple of days, and I did an ultrasound, and she had, good going synovitis there. So fairly quickly, to be honest with you.
Yeah, yeah. No, that's interesting. Um, Next question from Louise. So, for a lot of the accredited courses, a mentor is required, as you touched on earlier, Kasim. How can people find one? This is a question we get a lot of PhysiQuip as well. Any advice on mentors? It's difficult, isn't it? It's a big barrier, really, to.
Yeah, I mean, one of the things that I did was that, I mean, I kind of had an unconventional route to training, because at the end of the day, rheumatologist scanning people used to laugh at me. They used to say, "What, you want to do ultrasound? You don't want to do research in all these big kind of rheumatological conditions." They used to tell me, "Look, ultrasound is not going to take off in rheumatology." So there was just absolutely no one to kind of go to. But then I kind of looked around the country, actually, and there were a couple of rheumatologists that were doing, and I used to just speak to them. And then I realized, actually the only way to learn was to go somewhere where they were scanning all the time. And I think that's what you really want is, you've just got to, try and, find people, and don't be afraid to ask. I think the first port of call would be your local radiologist. Radiologists do prioritize their trainees, which is what happened with me. I had to go away abroad actually to learn, which I know, not everyone can do that. But there are lots of places where, if you ask, I'm sure people will be helpful. So yeah, that's what I would do. I think, your local radiology team or rheumatologists that scan, etc., or even orthopedic surgeons who are scanning on a regular basis. You just have to try and sort of, make the contacts.
Yeah, yeah. No, it's
It's a
difficult,
difficult
as you
answer,
say.
isn't it? There's no, I,
There's
I
no
know it's not a
perfect answer for that
satisfactory
one, is
answer.
there? That might be a question we might be able to help with, Louise, as well, just to give you some further information on that, regarding, some of the clinicians we work with and contacts. And I know that certain training providers are offering mentorship programs now, which obviously do cost, but it is a way around that if you are interested in, obtaining that formal accreditation in ultrasound.
Yeah, I mean that's the other thing. I know there are, a couple of providers out there that do provide some sort of mentorship. So that's, ultimately everything is going to cost.
Yeah.
I did a fellowship and, I did it for 6 months and I didn't earn a penny. I had like a little bit of a bursary and it was just, savings and, but I really, really wanted to learn. So yeah, I think, speak to Jamie, Louise, keep in touch with Jamie, and I'm sure, we'll talk about a few things related to this.
Yeah, we'll try and help you with that. Next question, how do you utilize ultrasound in your day-to-day practice? So I imagine that question might relate to sort of, do you have extended appointment times perhaps to allow for that examination? Do you use it on every patient? Or, is there criteria so that you qualify patients, filter them before, they use
Yeah.
that they have an ultrasound scan?
I think that's a really good question actually, because sometimes I think people can get very carried away once they learn ultrasound and you just think and want to use it on everyone. So
Yeah.
the first answer is no, you can't use it on everyone. I don't use it on everyone because I don't have the time, and it's not necessary on everyone. Okay, there's a select group of patients that need it. So my practice, the way we do it is that we have what we call an early arthritis one-stop shop clinic. So there's four consultants that are seeing patients, a registrar, and then one of us is scanning. So we'll see patients and say, go and have a scan, and then that person does the scan. Then the report goes back to the consultant that saw the patient, and then they make sort of a treatment plan. And then we kind of rotate round who's scanning. So I'm quite lucky because my other colleagues at Stepping Hill also do ultrasound as well. So we have a rota, scan time. Now, I know a few other people that don't have that luxury and they're scanning by themselves. And what they do is they just have an extended time, as you said, Jamie. So normally for a consultation rheumatology for one patient is around, you know, 25 to 30 minutes. Depending on how quick you are or how competent you are, I think you can do an ultrasound within 10 minutes or so, and then it gives you, a bit of time to have a discussion. So I think you're looking at 40 to 45 minutes per patient. Now, the way we've done it is that, because we have that one-stop shop clinic, it helps with our managers because they don't want us to just, just see one patient in 45 minutes. We can't, it's really hard to sort of justify that. So that helps in that regard. Now, one of the other ways that I tend to use ultrasound as well is I have a general clinic as well. And when I have a general clinic, I tend to sort of do disease monitoring. So a lot of our patients are on biologic treatment, and what we want to do with these patients is really make sure that they've got very, very tight disease control. Sometimes, again, they're the typical patients who say, I've got a little bit of pain, but you can't see anything. But these are the patients that I'll probably see. So my general clinic will have lots of my follow-up patients who I'm kind of assessing for their disease control, just kind of a disease status, you could call it. And it's really important because ultrasound can detect these changes and we can make, changes to treatment and things like that as well. And then lastly, I also do guided procedures as well. So I have a specific kind of guided list, you could say, and I kind of do everything, hips, knees,
Okay, yeah.
flexor tendons,
Would you
whatever
do
you.
those in one list, Kasim, just to keep it nice and streamlined and, so
I
yeah.
like to do that. Yeah, I'm pretty OCD about things like that. Actually, I like things in a certain way, really. So yeah, I try and streamline my kind of lists. General list, procedure list, and also kind of a one-stop shop EIA type service.
Yep, yep. No, that's really interesting to hear sort of how you actually implement that within your existing clinics. Next question, can you share any latest articles to support POCUS for rheumatological conditions? So, has there been any studies that looks at, the effects of POCUS? What does it do in terms of patient referrals? Onto radiology? Does it enhance the patient experience? Does it enhance the clinician experience to be able to offer a more thorough service to the patient?
Yeah, I think there have been lots of studies looking at this actually, and I think if you look at the literature, you'll probably be able to find there are quite a few things. So, I mean, one of the first things that with rheumatology is there are national recommendations to see patients with EIA within a few weeks. And when I say see them within a few weeks, then they have to have a diagnosis and treatment within 6 weeks of seeing you as well. So referring them to radiology is not the answer. So we have to see them so we can give them. So, this is how ultrasound kind of fits with that. It's kind of meeting sort of national standards.
Yep.
So yes, I think there may not be lots of overwhelming evidence that it can sort of improve from this point of view, but it is about sort of meeting the nice standards. Then I know that some other people have looked at cost effectiveness of ultrasound as well. And what they found is that because you do ultrasound in one sitting, you give them the diagnosis, it reduces all those other hospital appointments. You can see other people in that time, and there's quite a significant cost benefit as well. So that's why our kind of management team, are quite sort of proactive with this, and they're quite keen for us to, to be able to be able to utilize this.
Yeah, yeah. No, I think the benefits are clear, aren't they? Um, Final question, Kasim, because I appreciate you probably want some downtime this evening. Um, so I assume a one-stop POCUS rheumatology clinic within the NHS isn't always common practice
No.
across different hospitals. So, what are your thoughts on this, and how should the NHS and healthcare be evolving to actually incorporate ultrasound more, given the clear benefits that we just outlined on the previous
Yeah.
question?
Yeah, I mean, I agree. I think there are benefits there which we can obviously see, but I think a lot of the time, I think, within sort of NHS organizations, I think if you are trained in ultrasound, I think you have to present the case to them.
Okay.
Um, our kind of model is unique. There are a few places up and down the country that do this. But what we've shown is that, through that, in terms of, leading on from the last question as well, we've shown significant cost savings and patient satisfaction through kind of local audits that we've done and local sort of QIP patient satisfaction stuff. So it's really beneficial for management to be able to see that now. a lot of the time, if you look at other specialties, they are always talking about one-stop shop models because that is usually best practice. So if you go to urology, there's a there's a one-stop shop urology clinic. If you go to stroke, there's a one-stop shop. So I think, it's in the interest of NHS organizations to move towards one-stop models because it saves them so much money.
Yeah,
And
it makes
it
sense,
really
doesn't it?
does.
Yeah.
It just makes so much sense. So, I think a lot of the time it's not having the right people, So I know I think if you are someone who can do ultrasound, who can provide this service, and if you can show that to your managers, they will bite your hands off.
Yeah, I agree. I agree.
They will bite your hands off. It's an absolute no-brainer.
Yeah, I think, different members of staff within healthcare have different motivations ultimately, don't they? Whether that's improving patient outcomes, whether that's KPIs on appointment times or financials. And I think it can work to appeal to all of those different stakeholders, if you will, can't it?
Yeah, ultimately, I think, you have to show that, you can build a case really. I think we try and provide a case that, rather than just focusing on, yes, we could not do a one-stop shop clinic and we could see more patients, but then the quality for those patients is not the same. So
Yeah.
we can show that model, then and we're like I say, we're fairly unique in the Northwest because that I know all the other rheumatology departments around the region, and there aren't many others that have our model. There is Liverpool Aintree Hospitals, which do have this model, and us, and not many others. I know that there are single practice rheumatologists that do ultrasound who kind of do that model that I was talking about before, that extended kind of time, which again, it can show that even though you may see fewer patients, you can actually reduce their subsequent hospital visits, etc. And also, it's about meeting standards as well. So if we've got a big audit going on looking at inflammatory arthritis and how we're managing now. If trusts are shown to not meet these standards, then it looks quite bad. So it's a no-brainer to me.
Yeah, I agree. I agree. I think ultrasound is paving the way for, clinical improvements and patient improvements as well,
Yeah.
ultimately.
And ultimately, we've said it before, ultrasound is, I'm not a sonographer, but I can scan, but I'm a clinician, I take pride in being a rheumatologist, because I'm relying on my clinical history, my examination. Ultrasound is an extension of that. What do you want to call it? Rheumatologist stethoscope, lots of different things that people, talk about, but that's the way it should really be used. You're improving your clinical kind of idea of what's going on
Yeah, it's
your
not
clinical.
replacing anything, it's just adding value to what you're already doing.
Yeah, and a lot of the time it's about getting it right first time as well. So, if you can diagnose the patient correctly at the beginning, I've presented fairly straightforward examples, but there's lots of gray areas. Like, in my own clinic, I will see other patients from other colleagues to say, can you please scan this patient? Tell me what you think. I thought it was rheumatoid arthritis, but it's not behaving like rheumatoid arthritis. Could it be something else? And then you scan and say, well, actually, yes, you're right. It is rheumatoid, but the treatment that you've got this patient on is probably not enough. But because it was all subclinical disease, it's not really presenting. And sometimes these patients, may not have elevated inflammatory markers. They may not, show up on other things. But ultrasound can dramatically improve their outcomes and your satisfaction as well as theirs.
Yeah, yeah, no, definitely. I know I said that's the last question. If you're okay, Kasim, I'll do one more because it's just come in, but this is the final question for the evening. Is there any evidence or reasoning to support MSK ultrasounded guided injection is superior to blind landmark guided injection? Now, I assume, again, it's a bit of a broad question. Guess it depends on what joint you're injecting.
Yeah,
Qasim, would
yeah,
you agree?
absolutely. Yeah,
Um,
it's funny actually because I mean I did a big literature search actually, and we were supposed to publish this, and I think what we found is that the I think in terms of guided injections, I think they provide more accuracy. So, in terms of long-term outcomes, maybe, it's not shown that it shows any improvement, but it definitely does improve accuracy. And through that accuracy, it means that, you avoid complications and any sort of adverse outcomes, from guided injections.
yeah, so you're not going to hit a nerve, for example, or yeah, or
Yeah.
whatever it may be.
Yeah. So, I mean, the evidence at the moment is that, it may not improve someone's, long-term pain, but in terms of accuracy and reducing complications, yes.
Yep.
But,
Okay, dokes.
but at the same time, I will say that, you're right that at the moment that there isn't a lot of evidence out there actually. There isn't a lot. And I think if we look at specifics, if we look at rheumatology stuff, like, if someone was to say, does it improve, do guided injections work better in RA versus palpation guided, then there isn't the data there.
No, no, no. It's an interesting one. I think, from the clinician's perspective, it gives you the peace of mind that you injected in the correct spot, I guess.
Yeah.
And if it doesn't work, you know that it wasn't a case of you weren't in the right space. Um,
But it does also make a lot of sense to me from a clinical point of view. For example, if someone has got polymyalgia rheumatic of their shoulders, now, I could just inject blindly, but if I do the ultrasound and it shows that actually someone's got a bit of bursitis, and if I direct that injection directly into that area of bursa, to me, that's a lot better than just, giving a general kind of, an injection throughout the joint.
yeah, no, I agree. There's definitely value to ultrasound guided injections, isn't there?
Yeah, and I mean, sorry, Jamie, just to
No.
finally add is that, with ultrasound and rheumatology, people think that rheumatology is a disease of the joints. Yes, it is, but also it's a disease of the tendons as well. And the pericapsular tissue, etc., as well. So this is again, we look at patients and we say, okay, you've got psoriatic arthritis, your knuckle joint is swollen, but is it the joint or is it the tendon? Ultrasound can differentiate that. And if it can differentiate that, you can guide the injection directly into that region.
Okay. Yeah. No, that's really interesting, Kasim, and a good overview of that. Well, thanks everyone for joining this evening, and obviously a massive thanks to you, Kasim, for presenting. We appreciate your time and expertise. So following this, everyone will receive a link to the webinar recording, and also for those that couldn't make it live this evening, that resource will be available to you. If you want to get in touch with any further questions on ultrasound, please, get in touch with us. The contact details are there on the page. And yeah, thanks again. We're going to be hosting some more webinars and workshops throughout the year. So please check out our events page and hopefully we can help you on your clinical journey moving forward. Okay. Thanks, everyone. Thanks again, Kasim. Enjoy the rest of your evening.
Right. Thanks, Jamie. All the best. Okay.
Cheers. Take care. Thanks a lot.